If you don't know me, my name is Josh Legler. I'll be facilitating the call today. This meeting is being recorded and it'll be posted on the Nemesis Tax YouTube channel. So if anything comes up during the meeting that you feel like we need to cut from the recording, just let me know and we'll take care of that. Before we jump into today's call, I do want to give an opportunity to hear intros from anyone who's new, who has not been on these task force calls before. And I know we have at least a couple of you helping us out today with understanding the hospital perspective, what information hospitals need to receive from EMS. So if you're new to the group here, haven't been on these calls before, go ahead and take an opportunity to unmute and introduce yourself.
I will. My name is Christy Brown. I am the Director of Trauma at Parkland Health at the Reese Jones Trauma Center in Dallas, Texas. We're a level 1 trauma center, and was included in an email and replied to Josh to try to help out to tell you what we use here, and I'm happy to, grateful that you guys invited me to join the meeting.
Thanks, Christy.
I'm Valerie Quick. I'm a longtime EMS provider, 30 years. I was an EMS liaison for the University of Virginia Health System, and now I'm the manager of the trauma program. We're also a level 1 trauma center.
Okay, thanks, Val. Anyone else?
Hey there, I'm Coleman. I'm an EMT, a student, a researcher, and I've been doing some quality improvement work at my local hospital at the University of Vermont Medical Center. Just here for the first time on one of the calls, want to hear some of these perspectives.
Okay, great, Kalman, welcome. I think that caught everybody that I saw that was new on the list. So thanks for introducing yourselves. All right, so what we're looking at overall, we've been through a bunch of topics in the EMS Interoperability Task Force meeting since February of 2023, and we're getting down near the end of our list of topics. So we have the call today where we'll be focused on the information that EMS needs to share with the hospital for continuing patient care and other purposes within the hospital. We're going to have one more topic to cover in May, and that's kind of working our way backwards in the workflow, going up to the very beginning of the workflow. What information does EMS need when they are responding to a 911 patient's medical history information, that kind of stuff that will help them to treat the patient. So that'll be our last topic within that category of what information is needed to be used in the various steps of the workflow. As you can see, we've covered a bunch of the other stuff, the government and regulatory environment, the networks, data exchange partners, the overall workflow sequence diagram that we looked at, the standards and profiles to use, IEG profiles, HL7 standards. We did patient identification and record matching, all of that stuff. So getting near the end here, so we'll have today's topic and then the call in May. And then at the end of today's call, I would like to gather feedback from all of you on if there's anything we missed, if we need to have another call in June, either as kind of a wrap-up call or any additional topics that you feel like were really important for us to get to on the task force. So be thinking about that throughout the call today, and I'll ask you for some input at the end of the call. For today, I want to briefly take a minute to just show you a data transformation resource that I published a few weeks ago. But we're going to spend most of the time today talking about this topic of what EMS data is needed by the hospital receiving the patient. At the end of the call, I do want to also take a minute to talk about one of the takeaways I had from my meetings that I had at the HIMSS conference last month, and in regards to operations queries in TEFCA. So we'll take a minute for that towards the end. All right, so today's question, what pieces of information does, not outcome information, just information. What pieces of information does the hospital need from EMS on its patients? So in the workflow sequence diagram, we're looking at this spot in the middle that I highlighted in yellow, where EMS is bringing a patient to a hospital, or they have brought the patient to the hospital, and they're sharing information with the hospital. Today, we are not going to focus on how that information is shared, whether it's over the radio, whether it's a verbal report, a paper handoff, whether it's utilizing a network or electronic exchange of information, whether it's using an particular HL7 standards for transferring that information. All of that we're kind of setting aside for today's discussion, and we're just talking about what is the actual content. What does the hospital need to know from EMS, regardless of the format or the mechanisms by which they might get it? I reached out to several people prior to today's call and got some perspectives. Got the emergency department's perspective, which is the one we will dig into first. Then also looking at the trauma registry perspective and the perspective for cardiac and stroke registries, kind of cardiovascular registries, as well as a little bit of additional information that maybe didn't fall into those categories that we'll look at. There may be perspectives that I missed. So I want you to be thinking on today's call of other perspectives that we might want to reach out to and get some input from. But we're going to dive into these perspectives and want to just kind of open each of them up for discussion. I'm going to share with you what I collected from people prior to the call that's kind of at a high level, and I think all of you can help us to maybe dive in a little lower level on these pieces of information and really develop some understanding around what exactly it is that the hospital wants from EMS in terms of that information. I'll also say, it's common, I think, for people to say, well, we want everything you've got. And then once you give them everything you've got, then they're like, well, never mind, that was too much. And part of that, comes down to system design. So systems that are designed well are going to surface the most relevant and important information. They're going to visualize the information. They're going to provide trending. They're going to provide highlighting of the stuff that's kind of outside of normal. That's all kind of system design stuff that we're going to leave to software vendors to do and to make products that are competitive in the marketplace. Of what we want to understand here is just at the core, what is the actual information that is needed by the hospital? So let's go into the emergency department perspective first. I got feedback from a couple people that used this MIST acronym. And first of all, some basic patient info, the name, age, sex, and weight. And then the MIST acronym was kind of broken down to M being either the medical complaint or in a trauma call, the mechanism of injury. I representing the illness for a medical call or the injuries for a trauma call. And then S being signs and symptoms and significant medical history. And T being the treatments that EMS did, medications and procedures. So it was kind of cool to see that two different people sent me this same info from different emergency departments in the country as something that they had kind of settled on as being the most important things that's needed right away in the emergency department. So let's open this one up for discussion. This is really high level, so I would appreciate any thoughts that all of you have on, maybe fine tuning or digging into the details a little bit about what's needed by the emergency department. So any thoughts on this list and how we can kind of refine it or understand it better?
Gosh, so we've had discussions around MIST in New Jersey. There hasn't necessarily been a set standard on that. Our organization of 14 hospital uses an SBAR format, situation, background, assessment, and response. So it's a similar structuring, but I think the biggest piece is settling on a consistent standard so that we're giving a structured report every time. And really we can, sitting with the hat of both EMS and hospital, we can help drive how that's going to be interpreted to a degree, as long as we can be consistent about it.
Oh, great. That's really helpful. Thanks.
We've been focusing on the mist too. We have an eye mist and the patient it's identify, the patient.
Got
So,
it. Okay.
but yeah, it's same sort of thing. And, the only variation that we put on it was, vital signs, including, any major changes. So like the lowest, blood pressure, any hypoxia, events, those types of things that we put in there.
Yeah, we also look for in the ED receiving, we also look for those kinds of extremes of vital signs.
Yeah, good. Those outliers. They might have taken 5 sets of vital signs on the call, but if the blood pressure was really low in one of those sets, or in multiples of those sets, that's kind of a highlight thing, right? All right. Any other comments on the emergency department perspective?
I think having those drug admin doses and times can be especially helpful, especially for the more critically ill patients.
Dosage and times, yeah.
Can I ask one clarifying question with this? Is this
Yeah.
the intent of an initial or a full report to come across?
That's
So,
actually a great question. Yeah. Tell us a little more what you're thinking.
so for me as a clinician, I go in, I go to the charge nurse, I give a similar report to this. It's the rapid, high level,
Mhm.
30 seconds structured report of, what happened with the patient, what's the chief complaint, what's their pertinent background, what did I find, what did I do for them, all that. So that SPAR format. And then when I actually get to the care nurse or to the physician, I give a more detailed assessment. Again, similar structure, just going deeper into it. And to me, the question would be, are we looking at the full, like the be all end all document that they're looking for, or are we looking at just that initial communication? Because I know one of the points I did share with you offline was looking at getting some sort of pre-notification information over. And to me, this is a perfect pre-notification where I hit one button, I push it, it starts the registration process, it starts the alert process to the receiving facility, but knowing there's still more to give.
Yeah, excellent comments there. I think, I mean, we got to look at both of those stages, and that's kind of, I think that's, when I showed this step here, it shows it as one step, right? We push a transport summary, and I think we maybe need to break that out a little more. I think maybe what the real workflow is that EMS shares some basic information early in the process, and then they share a more complete report later. You think so?
Agreed. And the other thing I'll comment is looking at the hospital PCR side or EMR side, it's an ongoing document. It's something that goes back to historic as well as future looking. EMS tends to be transactional. Here's our one interaction with the patient and share it. So it does kind of impact that piece as well. So kind of how you look at it plays a part.
Yeah.
And I think I'm one of the newest people here and had just, gotten an email asking for for assistance with what y'all are looking at. And when I immediately read the ask in the email, I immediately thought, okay, this is our EMS timeout when we've had pre-notification. Our trauma team is at the bedside. EMS arrives. They almost always give us, we give them the EMS timeout. We will quiet the room, and they will give us their report that is most often in this missed setting. Then the trauma team will take over care, and if there's more specifics that the EMS need to give, they will then give one-on-one to the nurse that's documenting while the team is already beginning their primary and secondary surveys on the patient. And then I think after I had sent you this, Josh, I then put in parentheses, if you're talking like, what do we need for our trauma registry? That's a whole different conversation. And so that's, more or less just the complete run sheet. So yes, two, kind of like Neil said, it's kind of two different things. One is that immediate patient drop off. And then the other is what do we need within, 24 hours or, after they've completed that time, their medical record when, or pre-hospital record, when is that dropped off? And so yeah, two different kind of things, but our immediate EMS timeout here in the Dallas area, it's almost in this type of a missed perspective.
Good. Okay. So from what I'm hearing, it sounds like the MIST or SBAR acronyms kind of do a good job of explaining the basics that EMS would need to communicate to the hospital up front. And then we look for a more full report later. All right, let's go to the trauma registry perspective. So, trauma registrar, they're putting in their trauma record potentially days or even weeks after the event happened. And what I saw from trauma registry in general was we need identifiers, the patient and record identifiers. That includes the UUID from the latest version of NEMSIS as that universal record identifier. You need EMS times, patient demographics, the scene location, all that stuff, details about the injury, cause of injury, mechanism, vehicular injury indicators, all of those. Vitals, including blood pressure, heart rate, pulse ox, respiratory rate, CO2 and GCS, procedures that EMS did, and their transport method to the hospital, usually air or ground. Any additional thoughts about the trauma registry perspective, like in terms of what's important, what the trauma registry needs, or what the trauma program needs, I guess we could say too?
With the injury details too, any safety equipment or lack of that. So with seatbelts, were seatbelts used, helmets, any of that, and that is often very difficult to find now.
And I would add in the ability to provide some sort of patient follow-up or feedback to the crews. I know our organization does try to provide that to meet some of the ACS standards, and it's a moving target, especially with our volunteer organizations, as to who the point of contact is and how to get it to them.
Oh, okay.
Yeah, that's where that complete run number helps. As far as us being in the large area, if we can get that complete run number, then we can try to get that assistance. The only other thing, I know it's probably listed under the procedures, but we have a specific block for IV fluid, how much was given on scene or in transport. But we do have that a specific looking at IV fluid.
Okay, yeah.
So in addition to IV fluids, it's starting to enter the EMS world, and especially in critical care transport. What about blood products?
Yeah.
Yep.
And whole blood versus PRBCs.
Versus component therapy, right?
Yep, exactly.
Okay. Great.
And the only other thing that I would add, and I think that having knowledge too of anybody else that was on scene, many times, like we get the run reports of the patients that come to, or the agencies that come to us, but it's that first agency that may have done, like for the STEMI, they care about first medical contact and when the EKG was done. And sometimes it's hard for us to know what other units and agencies were on scene that helped you with this. So having that in the report is helpful so that we can, do some backtracking if we need to.
Right. You can try to go get their report if you're missing it. All right.
Yeah, and I think about especially with traumas in more rural areas, like where I'm at, we have a lot of, like flight scene response. That's there could be a pretty, not extended, but enough on scene time provided by a completely separate agency. So yeah, have that data handed off.
Yeah. Okay, cool.
And barriers
Uh,
to care, like,
Oh, okay.
extrication time, they had to go on a trail and find somebody, anything that kind of extends that period out, just knowing that.
Okay. All right. Anything else on the trauma registry perspective? Let's move to cardiac and stroke registry perspectives. There's a lot in common here with trauma, right? You need the identifiers for the records and the patient demographics, EMS times. A couple things that came up in this category would be the onset date time when the problem started happening, symptoms and impressions that EMS had, any current medications that the patient has been on. Vital signs are really focusing here on those cardiac vital signs. So the first ECG, blood pressure and heart rate, medications that were administered, and again, transport method. Any other thoughts from this kind of the cardiovascular registry perspective?
So I think my comment is probably going to be true of any time critical illness, but especially salient to the STEMI discussion. There seems to be some difficulty in acquiring hospital notification times at high fidelity. And from a NEMSIS perspective, I don't know that that's going to be fully addressable simply by changing the NEMSIS fields, because if you're entering it in after the fact, of course, it's not going to be as high fidelity as if it's imported directly at the time of the notification. As a surrogate for this in our hospital system, we've been taking the timestamp off of the 12 lead EKG that's transmitted and using that as a surrogate for notification time. But I do wonder whether or not importing 12 lead transmittal time and making that actually a NEMSIS field would be beneficial in terms of identifying things like time until hospital notification.
And you're talking transmission time, not actually or what's the word I want? You know what I mean?
Yeah, like the actual radio time. And this is obviously a limitation. The highest fidelity measure is going to be the radio notification time, because there will be times where, for example, an individual acquires a 12 lead that's concerning for a STEMI, and they're on the 10th floor of a building away from the Wi-Fi of their ambulance, and there's going to be a gap between those two. But we have to count on the person to manually record the time that they think they made the notification, which may or may not be totally accurate. It may or may not be completely filled. And so having a transmittal time at least is some form of surrogate marker that will probably be able to be saturated into the chart with high reliability.
Yeah, okay. So if I'm understanding what you're saying, we have the timestamp of when the ECG was actually acquired from the patient. Then we have a time when EMS may have communicated with the hospital that they've got a particular cardiac problem that's coming in. We also have a timestamp of when the ECG was actually transmitted to the hospital. That would be kind of the hospital's first opportunity to start seeing that patient's ECG. Did I capture that correctly?
Yes, you did. And the reason I say it's most salient to STEMIs is without actually capturing information on these pre-hospital notifications, it's very hard to assess your false positive, false negative, all these kind of rates. How good is your sepsis screen, and about your stroke screens? Those are all going to be limited and maybe not specifically a NEMSIS issue, but I think the STEMI in particular, there are discrete data fields that could potentially be populated that could help address this question.
Yeah, okay, great. And Michael, I think you came on a little bit after we started the call. Would you take a sec to just introduce yourself, where you're from?
Oh, certainly. I'm Mike Spigner. I'm an EMS physician at University of Wisconsin, and I serve as our Director of Pre-Hospital Medicine Informatics and our Chair of Quality and Patient Safety.
Great, thank you. Other perspectives or comments here on the cardiac and stroke registries? All right, I'm going to move to just some additional ideas that came in as I was compiling these lists. And one, Mike just talked about the pre-arrival alert or activation. So EMS actually notifying the hospital that they've got a particular condition, whether it's trauma, STEMI, stroke, whatever, and alerting the hospital. And then a couple other things that came in that were kind of, you know, a little bit different in nature, but are certainly things that would be uniquely known by EMS and not others. One was the conditions at the patient's residence, if that's where the call happened, or the scene where the patient was found. And then another was family member contact info. So we've got this patient coming in, who do we contact to let them know, you know, let family know that we've got this patient. So that was a couple other things that came up. Valerie, I think the information you had collected included these things. And I want to open it up here. You know, so we went through the ED perspective for kind of that initial report. We looked at the different registries, those perspectives. We got a couple additional considerations here. What else did we miss? Either other pieces of information that would be important for the hospital to get from EMS, or maybe some perspectives that we need to go do some homework later and reach out to people and you know, get different perspectives from.
Josh, the only other thing I would mention is, and I did put this in my notes, is not, and I'm sorry if I missed it, I was typing in the chat some, it's not just our PCR, but some of our other findings. So for instance, our EKGs, getting those into the hospital medical record. If we're doing any other diagnostics that generate a result, how are we getting them into the system? I know there was some, when we originally built our interface 6-7 years ago, or 5 years ago when I took over and updated it, there was a huge pushback on the EKG imports, and part of that was from the vendor, but it's something that becomes very important to be able to get in, especially for our STEMI patients, or a patient where they may be getting a pacemaker or a pacemaker defibrillator. That specific content is critical.
Okay, thanks. All right, well, do y'all feel like we covered it? Again, our overall question, which we've gone through pretty quick so far, was, you know, what pieces of information does the hospital need from EMS? Hopefully we've covered that question, but do y'all have thoughts on anything else that you feel like we need to kind of go back and look into?
The only other thing that I would bring up, because there's some discussion about it locally here, is we have an ongoing quality improvement project related to the accuracy of weight estimation of pediatric patients by EMS clinicians, which is very challenging because there's really only one commercially built stretcher scale right now that's not widely employed. So we're using weight-based methods and things of that nature that are inaccurate. Locally, we have modified our EHR to include a field that captures not only the patient's weight, but also the source that they used, in terms of whether it was a weight-based tape like a Broslow, or if it's some other kind of, you know, age-based method or something of that nature. That's been very important locally in trying to drive changes in protocol and policy for measuring these patients to improve accuracy. But I think as I look forward into the future, knowing that scales may be on the horizon, being able to capture that data on a larger scale nationally, for example, would be very helpful, I think, from a research perspective and trying to address the issues of medication error in this population.
Okay, yeah, thank you.
Hey, Josh, can we ask the question the other way around for a minute, since we have a few minutes? And what information is absolutely not important to the hospital? Is there anything?
Yeah, that's a good way to put it too. Yeah.
You can think of just right off the top, like billing information. Is that important to the hospital? I guess your hospital based it is, but otherwise, are there fields that, you know, just would be a waste to transfer in?
I mean, I can't think of anything that's currently being given that I would say stop doing.
we have a few kind of maybe esoteric things in EMS, but maybe they are relevant. So one section I can think of that I wonder what you all think about is the PPE that was being worn by the EMS crew. Like, does the hospital need to know that?
That becomes
That
important.
actually came in handy when I was doing investigations on like you know, a meningitis exposure to see if they, you know, had used their PPE for that, even during the COVID. If there was no PPE documented, then you know, my worry and my need to escalate that as quickly as I could went up. So I would say it from that perspective, that I think it is useful from a disease reporting, and hospitals have a standard that they have to report certain diseases, and that should be part of what they're looking at. And I think that especially if you're the infection control officer, you need to make sure that, you know, those things are documented too. So unfortunately, yes. I can't think of anything to take off, which is a problem.
Well, it's not a bad thing because at the technical level, EMS can just share everything they have, right? And then it's important for the software that's receiving that data to be able to parse it and say, okay, the ED needs this, the infection control person needs that, and so on. Neil, I think you were going to say something.
No, actually, Val hit that nail very squarely. So thank you for that. It's all infection prevention and exposure comes to play. So.
Yeah, I suppose even, I mean, I could ask about odometer readings from the ambulance.
That's the one I was thinking of, was the vehicle information itself.
Yeah.
My only hesitation with that one, Eric, is that in our service, we use unit designators in the sense of here's your shift that's different than the vehicle. In some services, the vehicle is their identifier. So if we need to track it back to a specific unit, it may become more complicated if it's not there.
So it doesn't sound like there's anything that's an absolute,
Like, don't give it
oh,
to
why
us.
would you send this to us?
Yeah, that's what it sounds like. Thanks for the question, Eric. That was a good way to look at it. Okay. All right. Well, just a couple other topics I want to cover for today. I realized I actually jumped right into our today's question without showing you the data transformation resources that I had mentioned up front. So I want to go ahead and do that. Take a minute for that. We're creating some data transformation resources to transform data between HL7 formats and NEMSIS format. We're looking at both directions for those transformations. And one transformation has been published so far. I put this out in early March. So I wanted to make you all aware that it's available, especially software developers. You'd be the primary audience for this, but I think it's helpful for other people, maybe from the documentation perspective, to know what's in it. So this is in the repository, the IHE EMS repository on GitHub. So I'll go ahead and put a link to that in the chat. You can follow that. It's in the transformations folder of that repository. And the first transformation built is taking an HL7 consolidated CDA discharge summary for an inpatient encounter and transforming that to a chunk of NEMSIS data that would encapsulate the outcome section of a NEMSIS patient care report file. So it consists of the transformation itself, which is an XSL file, and then it also has an example sample document of that hospital discharge summary and the sample output from the transformation in the NEMSIS XML format. It's also got some notes about the transformation. So it does take some patient data from the discharge summary just for identification purposes and transforms that data into the NEMSIS format in the e-patient section. but primarily the main functionality here is in the outcome section to grab the data from the discharge summary in HL7 format and transform it to the NEMSIS e-outcome data structure. So a software system could receive a discharge summary. They could run it through this transformation to get something that would be in like a chunk of NEMSIS XML. It's not a full patient care report, obviously, because it doesn't have any of the EMS info, but it's a chunk of NEMSIS XML that has that e-outcome section representing the hospital information. Then they could process that data into their database. And when they send the PCR to the state and onto the national database, then they could send it with that hospital outcome information included. So a few people so far have been kind of kicking the tires on this transformation and comparing it to stuff that they've written. I think it serves a couple purposes. One is you could actually just like grab this and incorporate it into software that you're building. But if you don't do that, I think it's still useful as a reference implementation and important, I think, for the industry to coalesce and agree on, yeah, this is how this data gets interpreted and transformed. So yeah, we all agree that this particular NEMSIS element is being sourced from this particular element in clinical document architecture. And we're all going to agree that we use that approach. So we get more consistency and standardization. So any transformations you've written as a software developer, you can compare to this published transformation and just kind of see where similarities and differences are. Wanted to see from those on the call today, if any of you, I know I've had some conversations with people who have been taking a look at this transformation. Any comments from anyone on the call today on if you've reviewed it or have thoughts about what it's doing?
And maybe this is a little bit more broad. I've been doing a lot of work with Virginia in trying to really make sense of the data. And what we sort of come to the conclusion is that the data is still very messy, and getting reliable information out of it is still a bit of a challenge. And I think that part of that comes with the nature. EMS sometimes is documenting after the fact, putting vitals in, putting what happened after the fact, and that can be difficult when you're trying to assess for how long a patient was hypoxic for, in between intubation attempts, or making sure that all the procedures are in there that were done and completed correctly versus, not correctly, like how many attempts it took to do things. Sometimes it's just the last one that was in there. And I think that is still a pretty significant challenge, especially if we ever want to be able to really do performance improvement out of outcomes, is knowing that that you've got reliable information going in, because right now the information coming out and the dashboards that we're running are just not, they're just not accurate.
Yeah. As I worked on this transformation, it gave me an opportunity to dig into data quality a little bit. I'm very familiar with the data quality variations that can happen on the NEMSIS side, and I got to learn a bunch about the same data quality variations that can happen in HL7 data, where they might use one code set or another code set for documenting their procedures or their medications, things like that. So I think this work is going to be useful from that perspective of that as we do it and we say, okay, this is how we're going to transform this data, it kind of uncovers the variability that exists out there, and we can say, okay, what do we do about this variability? How do we handle it? So yeah. All right, and thanks to Jonathan for the comments in the chat. Okay, let me get back to the presentation here. Oh, I forgot. Lisa, could you put the link to the survey in the chat? Or if you all want to grab the QR code here in the corner, that's just the post-call survey. We have a couple things to talk about here before we end the call today, but when we end the call, go ahead and take an opportunity to fill out, like 1 or 2 minutes to just fill out the post-call survey so we can follow up on anything that we didn't cover adequately today. Okay, so the last topic that I wanted to cover before we talk about kind of the ending of our task force calls is one major takeaway that I had from my time at the HIMSS conference in March. I had a bunch of meetings with people while I was at the conference, including 3 EMS software vendor companies, most of the TEFCA qualified health information networks, and a bunch of other people. Really helpful conversations. And there's, I think, kind of a key takeaway that I want to just cover with all of you and also get your insights on, is that as an overall goal, I think we really need to ensure that EMS interoperability, all the steps that we've identified in that, are fully supported in the Trusted Exchange Framework and Common Agreement, or TEFCA, which will be the future of nationwide health information networks and health information exchange. So the idea being that EMS, through their vendor, can plug into a qualified health information network, and by doing that, they're part of the TEFCA framework, and they can exchange data with any other healthcare provider in the country. And so as we look at what is and is not supported today in TEFCA, getting patients' medical history, that's so EMS querying the network for patients' medical history. The exchange purpose for that query is a treatment exchange purpose, and that's fully supported in TEFCA. So if you query the network for patient's medical history, you're doing a treatment query. Any other nodes on the network who have information for that patient, they have to respond to that query and provide the information. So that's great. And then EMS sending its data to the hospital, and the hospital being able to get that data from EMS, that's also for treatment purposes. And so that's also supported in TEFCA. So that's great. The piece that is not strong right now is when EMS queries the network to get the hospital outcomes. The purpose of that query is operations, because EMS is no longer at the patient's side treating the patient, but they need that information for improving their overall system and the care that they provide in the future. So today, operations queries do not require a response in TEFCA. So other entities can choose to respond to operations queries, but they don't have to. And the thing that's kind of holding that up right now is that operations is such a large bucket, and EMS is just a tiny slice of that large bucket. So when providers open themselves up to responding to operations queries, the bulk of what they're going to have to respond to is stuff from insurers putting in daily queries asking for any updates on all the patients that they insure, and has anything happened, stuff like that. And so healthcare providers are having some challenges figuring out how they're really going to support that huge volume that operations queries consist of. But as I talked around with the QHINs and other people at HIMSS a few weeks ago, there's no concerns about EMS being able to get outcome data. There's no one saying, well, we're not sure we want them to have that. They all were supportive of EMS getting that data. And it represents a small slice of traffic on the network, because EMS knows exactly which patient, exactly which hospital to query to get those outcomes. So really no concerns from that perspective, which is great to hear, because it's not how things were 10 or 15 years ago, but it's where we are today. So it looks like a path forward that was supported by multiple QHINs that I talked to was that we pursue a sub-exchange purpose standard operating procedure within TEFCA. So it's an operations-clinical exchange purpose, that if someone submits a query for the operations purpose, but they are a clinical provider submitting that query, that be prioritized and that responses be required for that. So that would cover EMS asking for outcomes, that if you do have outcomes for that patient, you would be required to provide a response. And then we can let them sort out how they're going to talk to insurance companies, figure that out, and it might take a while. So that's what we're looking at as a path forward, is to pursue this kind of sub-exchange purpose within TEFCA. And wondered if anyone has thoughts on that, if it sounds like that's a direction that is reasonable to pursue, if it's going to be helpful, kind of move the needle forward.
Yeah. Hey, Josh, it's John Hodgson from Image Trend. I'll chime in here because I know I was part of those discussions, right?
Yeah.
So while at HIMSS, I had specific meetings with leadership from Commonwealth, Andy Health Exchange, and Epic, as well as our friends at No2, who we partner very closely with. And the suggestion from going in and kind of asking, I had this idea that we needed to do an EMS sub use case, but wasn't sure. So kind of went into the questions or meetings with Commonwealth, Andy Health Exchange, really seeking to understand, how should we go about this? What are your thoughts on it? And it's pretty much exactly as Josh described, right? They have no concerns. They're fully supportive of creating an EMS sub-use case, which would be the first sub-use case within operations query. No2 has already, Matt Becker from No2 has already gone ahead within the QHINs and proposed this EMS sub-use case. And Josh, my last chat with Matt, I think he said June was the next QHIN meeting. So it's been proposed, and then in June we'll start the process of comments and whatnot, as far as getting an SOP and stuff created that is specific to that. But yeah, we made a lot of great progress there. So thank you for your help as well. I really think that we've been with the task force here and our ability to kind of interact with these folks and push the ball forward. I'm hopeful that like by the end of the year, we might actually have operations query as functional. So fingers crossed.
Yeah, thanks. Any other comments on this approach? I want to make sure that we're, pursuing something that we think will be viable, and it really, again, that overall goal that let's make sure that TEFCA really covers what EMS interoperability needs, and let's not leave EMS kind of at the side anymore, but make sure they're really covered.
Hello.
Yes.
I don't know if you guys can see my hand, so I just figured I'd say hi.
Yeah, go ahead, Jonathan.
Hey, so I don't agree. A couple things. So I'll try to be brief. I put a bunch of notes in there. There's a couple pieces to this. So first of all, I would caution against the sub-use case, the sub-network model. I think there's value to it. So I don't think it's something that shouldn't be explored. But I think, and that was some of the early discussion I had with ONC orbited around that as well. But I would caution that creating a sub-network or a sub-use case creates a separation that may not be helpful in the long run. So the idea of saying we mobile medicine want to be treated in a different way, special, not always a good thing. It's something that EMS sort of gravitates to. And I think that can end up causing downstream challenges. So I would caution, again, have the conversation. There's nothing wrong with having a conversation. And I believe when we signed with a QHIN, we were pretty early in that process. So I've been doing this for a while. And again, there's nothing wrong with engaging the topic, but I would caution against the idea, just like, some years ago, we started talking about CDAs for EMS. That was a bad idea too. So I think to the degree that we start creating separate things, let's caution on that. A separate but related caution is and I'll get to sort of what I think is the best path forward in a second. But as I put into some of these notes, there is a perception everywhere in our space that EHRs are good. As some of you, including you, Josh, I think have heard me say, EHRs are the second, or the EPCRs are the second most hated documentation technology in the world, following EHRs. Many EHRs are seen as the primary source of burnout for clinicians across the United States, right? There's a lot of garbage in there. I posted a piece here from University of Pennsylvania just a couple weeks ago, I believe, where they're looking again at the quality of the data in those EHRs and lack thereof. So when we start looking at hooking these two together and facilitating outcome reporting and all of that, well, we run the risk of going into some of the challenges that some HIEs have been having, which is garbage in, garbage out problems. Don't think, you obviously have posted the 2.4% of outcomes and so on as a key metric. And I think you and I have talked about the question of, is that because folks aren't routing the data around? Is it because the data aren't available to be routed around? There's a lot there, and I don't think we should necessarily, again, go down too much of a path without making sure we're not going to contaminate our own data sets and waste a lot of time by doing that. So the third bit is community paramedicine and longitudinal care. And I think, again, there's much to be said on that. Not everybody here participates per se in that world, but I do think it's very worth discussing that the operations use case is weak for the obvious reason, as you mentioned, right? There's not a lot of incentive for folks to take their time to do that. So the real question is, can you keep these patients under your care? And so as you start to extend care outside the walls of the hospital, and you are aligning that with mobile medical providers, there is a very strong argument that this is not an operations use case, it's a continuity of care use case. And so the TEFCA model applies perfectly. And just to be frank, I mean, that's BLT's approach. So like we have been leaning in on that. Again, not every organization does CP for a range of reasons, technical, legal, manpower, all the things. But I do think it's very worth contemplating. If you're going to have this conversation around interoperability, you should ask yourself, are you asking for outcomes because the EMS agency wants it for its own benefit? Or are you asking because you are providing post-discharge care for the patient, and that distinction can be everything? So I don't think this is a hopeless conversation. I think it's really a question of, are we speaking the right language? And as, attendance at CP events and interest in that grows pretty significantly, I think we're hitting a bullseye, which is, that's a lot of wins to be had there. That's it.
Yeah, great. Yeah, thanks for those comments. I'll offer a point of clarification just on the first, which is this sub-exchange purpose. We're talking about data that the hospital already has, like diagnoses, procedures, discharge disposition, those things. Certainly there's questions about the quality of that data, but just looking at it's there today at some level. And exchange purpose is a concept that is defined and supported under TEFCA. When you make a query, that query looks exactly the same regardless of your exchange purpose, except for the one element in that query that indicates what your exchange purpose is. And so what we're talking about is that all the mechanisms using the TEFCA mechanisms, but just that when we do submit a query for operations exchange purpose, that requires a response if it's from a provider asking for that data. So
yeah,
not just special to EMS, but really, I think any healthcare provider kind of, making it so that it fits within the TEFCA structure and framework and doesn't look like something different.
Yeah, copy that. Like I said, I think I'm going to be talking about some of this, I expect, at FDIC next week, where we're looking at economic models behind community paramedicine. And this is a big part of that. So I think, to me, it's a question of, are we thinking about these pieces of the process in such a way that the rest of the ecosystem wants to play, right? And again, like you said, this is not limited to EMS. This could be everything from, if you walked into a store and you needed a belt, and instead you asked for a circumferential attachment that goes onto garments with holes in it, people are gonna look at you like you're crazy. Just ask for a belt, right? And so I think it's possible to overthink some of this, where we go in with a certain language, and that language is, I'm looking for outcomes. But if you're not thinking about, again, you've heard me talk about this in the context of insurance, right? If you're asking for question X, they're looking for question X, or excuse me, question Y, and you asked it in this way, you're not getting the answer. But if you tweak your language a little bit, you can sit at the table and have a great conversation.
Yeah.
So I think it's really just a matter of understanding what the counterparty is looking for, so that they can play. I'll give you a specific example, by the way. This is not theoretical. In California, UC Davis Health was, to my knowledge, the first major hospital system to put in writing that they will share data inbound and outbound with any fire, EMS, or community paramedicine agency requesting it. That was Michael Marchant. It's in writing. It's gone out to many agencies. But the proviso that he gave was, I won't do that with anything other than the standards that we use.
Yeah.
Right. So if you ask me for something special for EMS, the answer is no. If you say, give it, I'll give you and receive data in ways that either Epic supports or the hospital system supports or California supports, we're totally game. Right.
Yeah,
So
yeah, exactly right.
it's really about, all right, are we talking the same language? And so now EMS gets to learn, if they want to, how to ask those questions and offer the data in a way that they understand. That's a good thing, right? It's going to require some of us to build some new muscles, but that's not a bad thing. We just learn somebody else's communication.
Yeah, exactly right. Yeah, great. Thank you for those comments. Anyone else with comments on this future work with TEFCA?
So just to kind of dovetail on what Jonathan's saying, I don't disagree that community paramedicine will be a great opportunity, but I think we're 15 to 20 years from that. The ET3 trial was ended 2 years early for lack of enrollment, and we're facing a crisis in the profession on lack of providers. And trying to hang our hats on a new and upcoming service line that just does not have the personnel, where we can't get people on the trucks. I agree, there's a great opportunity and it could help get the insurance, get the financials. But I agree, Josh, where you're going. And Jonathan, I actually, speaking out of both sides of my mouth, I agree. What we're doing now, we're playing with Epic. We're getting ADT messages and getting all that content because we went to their sandbox. So having that specific use case to allow us to get into the pathway and get recognized and hopefully get responded to sooner is great, but we've got to follow their pathways.
Yeah, Neil, I would also say, I think to Josh's point a few minutes ago, and actually since TEFCA's still on the slide here, there are some conversations that are national in nature. There are some that are not, right? You're in Jersey, right? You guys don't make your life easy in any way, man. So that's a local thing, right? And I think and there are reasons sometimes, and there are not reasons other times. But for example, CP in California is growing like hotcakes, and it's taken a long time to get there, but it's phenomenal. I think it's always difficult to use one's own backyard as that example. There are a lot of efforts that are working in this regard. There are a lot of efforts that are trying. There's some stuff going around on social this morning from Colorado, where there are insurance companies, including United Healthcare, that are actively promoting community paramedicine and using success stories to do it. Right. So I think that's why CP, modes of care are difficult to discuss at a national level. But the purpose of these interoperability frameworks that have been worked on for over a decade, of course, is that you didn't want to have state by state exchange models. So that's one of these is a national conversation. The other, for better or worse, is not. I wish it was.
I'm
I mean,
gonna
again,
I'm gonna interrupt there, and then I think I'll pass back to Josh. I think we may want to move on. I appreciate about me. We've had some communications in the past.
Yeah.
And I do speak from a Jersey perspective as my primary experience, but that is not my only experience, nor my only perspective on this. So
I get that. What I'm saying is we got 50 states and a couple territories, right? So I think there is a lot of variation, but the point of the technicals, and it's why again I look at this conversation around extending the focus on care, excuse me, as opposed to operations. That's not a question. I mean, you don't have to call it community primary medicine if you don't want to, but it's the idea of the language that folks are looking for. The key word to provide some of the info that Josh is talking about is care. So there are lots of ways of making that work, that are locally focused, but they all, as long as they hook into that national model, then it provides the cover to get the thing done. I think where we put roadblocks in front of ourselves that are local, regulatory, statutory, procedural, whatever, right? Those can end up hindering the broader view. And again, there are states that have been more complicated, and some have opened the floodgates, right? And so some of those are seeing the results, for better or worse, of what they did locally. And in some cases it's working, and in some cases it's not. But that doesn't change the idea that TEFCA and its offshoots are national for a reason. And they're coming like a freight train, just like Nearest. By the way, Josh, at some point we need to talk about Nearest.
Yeah, sure. Jonathan, I'm going to
Jonathan,
cut you short now.
Yeah,
but,
we need to. Yeah,
we're
we're
gonna-
at time.
Yeah, we're gonna. Well, we've still got some time. Where it's an hour and a half call, but I think we'll be not taking the full hour and a half today. But want to bring us back around to our main topic here. And just as we go to the wrap up phase of today's call, just a reminder to fill out the survey, post call survey. Let us know anything we missed or need to look at next. The topic for May is the patient history information that's needed by EMS when they're treating a patient. So I'll be reaching out to people, but feel free to reach out to me so I can gather some information prior to the call and bring it for a discussion like we did today. And then I want to get your thoughts as we kind of bring the task force monthly meetings to a close here. So the last meeting that we have planned for now is in May, where we'll cover that last topic. The task force won't just completely dissolve. We're going to keep the Google group active. And I plan to continue to use that for collaboration purposes, because you're all a great group of people that have provided a lot of input and expertise. But we feel like we've covered the topics enough to know our path forward. So it's not like we've done everything and we're finished, but we know what we need to do next now over the next couple of years. And so we want to keep the group in place, be able to use that for collaboration, but not necessarily need the monthly meetings anymore, as we've really covered these topics. However, I want to open that up to all of you. Do you feel like we want to have, one more call in June as some sort of a wrap-up call? And if so, what would that look like? Or are you good with kind of finishing it up at the end of the May call next month? So any thoughts on that? You can share now, and then also, if you have thoughts to share by email later, you're welcome to, but I'd love to get some thoughts right now.
Josh, it's John again. I think we've covered a lot of good stuff. I think it'd be great to have a summary kind of wrap up call in June to kind of run through everything, from kind of start to finish, and just do a bit of a recap.
Okay.
Yeah, I agree with John. A lot of really good progress has been made, and we know what we need to do. So, at least our next step. So.
Yeah, thanks, David. So if we do a wrap-up call, just kind of envisioning what this would look like, we could kind of, one thing I could do is I could kind of summarize the key highlights of what we learned from all of the topics that we covered. that feels like me just telling you back what we covered. I'm trying to figure out like what else we might add that would make it useful for you. Any thoughts?
Might be nice as a group, since we've come a few steps together this far, to have knowledge of what other people are doing. So maybe some sort of insight into what is coming out of this, or like, oh, I heard an HIE was working on this, or somehow where we can get some type of update. Or I guess you probably know, if you go to HIMSS each year and you're in the group and your foot's in the circle when the conversations are, occurring, but so that would be interesting for me to learn about.
Okay. All right, anything else?
Josh, maybe if we had somebody like Matt Becker, who is, highly involved with the QHINs and what's going on, might be good to see if we could have Matt give a little update on things. If there's anything to talk about in the meantime.
Okay. Yeah, I can check. Thanks. Well, great. Thank you. I know a few people had to jump off at the top of the hour for other calls, but thanks to all of you for the input and contribution on today's call. I'll be writing up everything we discussed on the wiki that's attached to the IHE EMS repository on GitHub, keeping things documented there. Really appreciate all the input today. And we'll get ready for the meeting in May, and I'll see you then. Thanks, everyone, and have a great day.